So it's short status plus skinny plus um not doing weight bearing exercises. Okay.
Short stature, skinny, and not doing exercise. Okay.
Yeah, that's what I put. Yeah, short stature, not weight bearing. Yeah. Mm-hmm.
Okay.
And skinny.
Which of the following is the most likely diagnosis? A 20-year-old woman comes to the physician because of 1 week history of vaginal discharge. She is sexually active with one partner. They use condom inconsistently. She reports that she reports that he was recently treated for syphilis. Physical examination of the patient shows no abnormality. Pelvic examination shows white verrucous lesion of the upper vaginal wall and the cervix. A pap smear is reported for atypical squamous cell. Human papillomavirus is negative for high risk types. Which of the following is most likely diagnosis?
Ready?
Ready? Okay.
Condylomata cuminata. Condylomata cuminata genital warts, soft fleshy verrucous growth associated with human papilloma virus and can appear on the vagina, vulva, penis, and anal canal. Vagina, vulva. Okay. The most common implicated strain of are HPV 6 and 11, which both have low cancer potential. High risk subtypes like 16, 18, 31, 32 may also be present as and indicate a higher risk of progression to cervical dysplasia and malignancy. Diagnosis is made with examination and or biopsy if necessary. The goal of treatment of condyloma acuminata is to destroy the affected cells, and many methods can be used to achieve this. Topical formulations of podofloxacin, trichloroacetic acid, FU, fluoroacil, liquid nitrogen, and potential agents. Immune therapy is also used primarily with topical imiquimod, which stimulates the local innate immune system through toll-like receptors. Activation of local immune system then leads to recognition of viral particles and adaptive response is mounted. It's not what was that? CIN2 is a moderate grade cervical lesion with an increased risk of progression to cervical cancer. Cervical cancer is classically associated with HPV 18, the high risk ones, which are absent in this stage. While visualization of the cervix with colposcopy can show areas of whitening, when trichloracetic acid is applied, verrucous lesions are not seen. It's not secondary syphilis present with a rash scaly involving the palms and sore, um, along with condylomata lata. Condylomata lata are typically whitish gray flat top lesions which differentiate them from verrucous papules condylomata. Okay.
Okay. A 25-year-old woman comes to the physician because of 4 week history of right pelvic pain. She she has been sexually active with one partner for 3 years. They use condoms for contraception. Her last menstrual period was 3 weeks ago. She is afebrile pelvic examination shows 12 centimeter cystic mobile right at neck shell mass. Her CA-125 is 35. Serum beta is negative. Extra abdomen show calcium deposits in the mass. Which of the following is the most likely diagnosis? Initial mass 12 centimeter 60.
Ooh. Ready?
Yes.
Is cystic teratoma, damn it. Mature cystic teratoma are benign tumors of the ovary.
Your screen is
What
again
happened?
stuck. I don't know. If you want, I
Oh,
can send you the picture. I haven't
that's
like
weird.
you haven't choose any option. That's why I am confused. It never happened.
Oh, but I'm already at the, yeah, then it's
Yes.
stuck 'cause I'm already looking at the answer.
Okay.
Okay, that's weird. Mature cystic teratoma, now it's good now, right?
Yes.
Okay. Are benign tumors of the ovary. They are the most common ovary germ cell tumors, ovarian germ cell tumors, and typically occur in patients 10 ages 10 to 30. They contain tissue derived from all three germ cell layers, and as a result contain differentiated structures such as hair, bone, teeth. Patients often present with abdominal pain caused by the size of the teratoma, rapid enlargement, and associated ovarian torsion. Physical exam typically discusses unilateral or bilateral adnexal mass on pelvic exam, which may be tender. Definitive evaluation include pelvic ultrasound, which will show complex cystic adnexal mass with internal calcification like teeth and bone. Occasionally, mature teratomas can present with chemical peritonitis caused by rupture, and a small percentage become malignant. The treatment is surgical resection. It's not, where was I? The follicular cysts are simple cystic structure of the ovaries that occur during the process of follicle development when an egg is not appropriately released from a follicle during ovulation. Patients may be asymptomatic but can present with abdominal and pelvic pain if the cyst is large. Potential complications include ovarian torsion, follicular cysts do not contain calcium deposit. And it's not, what is F? Oh, fallopian tube carcinoma and ovarian cancer present similarly with pelvic and abdominal pain and bloating, as well as adnexal mass on physical exam. Both more commonly occur in postmenopausal women and are associated with increased CA125 concentration. The most common subtype of fallopian tube and ovarian cancer is serous adenocarcinoma, which is often discovered during late stages because of initial non-specific symptoms and thus carries a poor prognosis. Okay.
Okay. 5 weeks. Uh, which of the following is the most appropriate initial step in the management? 5 weeks ago, an uncomplicated delivery of the newborn. A 25 years old woman, gravida 1 para 1, comes to the physician, concerns about insomnia, restlessness, extreme fatigue, irritability, and depression. She does not she has not been eating well. She finds the baby crying increasingly annoying and has been letting him cry alone in the crib for long periods of time. She is having difficulty with memory and ability to concentrate. While her husband has been supportive, she has difficulty involving him in the care of the baby. She is afraid that she may hurt the child and says that maybe she would be a better off dead. Which of the following is most appropriate? 5 weeks.
Ready?
Yes.
Can you still see my screen or is it moving?
Sorry? No.
My screen is
Okay.
moving. My
It,
screen is fine.
no, no, it's stuck.
What? What is happening?
I don't know. I think that you did. Okay, now you I can see. Okay, I can
Oh,
see now.
that's weird. We never had this issue. This patient's presentation meets criteria for MDD postpartum onset, which should be immediately evaluated. MDD postpartum onset presents with the typical symptoms of MDD: depressed mood, decreased energy and hedonia, sleep disturbance, appetite disturbance, poor concentration. It may be delayed as much as 12 months after delivery. These factors for MDD postpartum onset include sleep disturbance, childcare stress, decreased estrogen concentration, breastfeeding difficulty, body image dysfunction, poor postpartum social support. Consequences of can be severe and include impaired bonding with the child, developmental delays of the child neglect, suicide, infanticide. The relative prevalence and severe consequences of MDD postpartum onset necessitate proactive screening for depression in primary care settings. Treatment of moderate to severe postpartum depression typically includes antidepressant medication, which poses minimal risk to breastfeeding infants and inpatient admission in high-risk situations. Is not C. Prescribing immediate antidepressant will not address the immediate concern of suicide and infanticide because most antidepressant takes weeks to work. An immediate psych evaluation will include safety evaluation and assess whether psychiatric hospitalization is necessary.
Okay. A 36-year-old woman, gravida 1, para 1, unable to conceive for a year. Her vaginal delivery 2 years ago complicated by postpartum hemorrhage and endometritis treated with DNC. She has not resumed menses since delivery, but does have cyclic abdominal pain. But has cyclic abdominal pain. Examination show normal finding. Semen analysis normal. Which of the following is the most likely cause? Okay.
With uterine syncytia, fibrous adhesions that form within the uterine cavity as a sequelae of injury to the endometrium. This condition is also known as Asherman syndrome. Okay, so remember the two names. Precipitants include endometrial trauma, in this case, curettage, and infections. Typical presentation includes infertility, which is common, spontaneous abortion, and menstrual irregularities such as dysmenorrhea or amenorrhea. Adhesions generally result from injury involving the endometrial basal layer, which leads to formation of fibrous connective tissue bands that often bridge the endometrial cavity. Diagnosis is based on the clinical history of a precipitant factor like prior curettage plus consistent symptoms of complication. The hysterosalpinogram that will show multiple filling defects in the endometrial cavity and incomplete distension of the cavity. Ultrasound and MRI may show synechia. Treatment includes removal of adhesions to restore appropriate form and function of the endometrial cavity. And it's not, it's confused with something else. Periadnasal
Adhesion.
adhesion. Periadnasal adhesion describe fibrous bands or scar tissue that occur adjacent to and involving the ovaries and fallopian tubes. Okay. This adhesion often result from previous intra-abdominal infections like PID or previous pelvic surgery. The structural disruption caused by the adhesions can prevent normal ovulation by interfering with release or tubal uptake of the oocyte. Amenorrhea would not be expected. And it's not tubal, no, I don't think I need to read that one. Okay.
Okay. Which of the following is the most likely cause of these patient's symptoms? A 32-year-old woman, gravida 2, para 1, 27 weeks of gestation, brought to the emergency department because of 3-hour history of painful contraction every 5 minutes. She has not had vaginal discharge or itching during her first prenatal visit. Routine urine culture grow 10,000 colonies of ruby Streptococcus agalactiae. She was not treated at that time because she was asymptomatic. She has no history of serious illness. Pregnancy had been otherwise uncomplicated. She takes no medication and has no allergy to penicillin. Her first pregnancy ended in spontaneous vaginal delivery at 33 weeks of gestation. Her temperature is 100, pulse is 100, blood pressure 90 by 50, and initial abdominal examination showed tenderness to percussion over the right flank. The uterus is non-tender and consistent in the size of 27 weeks of gestation. Heart rate 160, uterine contraction show every 5 minutes, lasts for 45 seconds. Cervix is up 2 centimeter dilated, 75% effaced. The vertex is as at zero station. Which of the most likely cause of this patient's symptoms?
Right?
Wait, one. Okay.
Okay, so it's pyelonephritis. Infection of the upper. Can you still see my screen?
Yes.
Okay. Infection of the upper urinary tract and kidneys. Is typically caused by retrograde spread of bacterial infection from the lower urinary tract. It is characterized by fever, leukocytosis, nausea, vomiting, severe tenderness. Symptoms of cystitis such as dysuria, urinary urgency frequency are typically present. In pregnancy, asymptomatic bacteriuria increases the risk of pyelonephritis. Thus, all pregnant women are screened for asymptomatic bacteriuria and should undergo treatment if found to be positive. Pyelonephritis increases the risk of obstetric complications such as preterm labor, which is defined as contractions with cervical change occurring at 20 weeks gestation and before 37-week gestation. Okay. The risk for fetal survival is greater the earlier preterm labor occurs. Okay. Treatment of pyelonephritis in a gravid woman, even if obstetric complications have not occurred, includes hospital admission for IV antibiotics. Even after the initial treatment course, suppressive antibiotics are continued throughout the remainder of the pregnancy to prevent recurrent pyelonephritis. It's not chorioamnionitis is a bacterial infection of the fetal membranes and commonly occurs in the setting of premature or prolonged rupture of membranes. Maternal fever and um, maternal fever and leukocytosis are characteristics, and the uterus may be tender to palpation. In this case, the patient infection preceded her preterm labor without rupture of membranes. Okay.
Okay.
And it's not, sorry, sepsis is the presence of organ dysfunction caused by dysregulated response to infection. It may accompany obstetric infections and account for a significant portion of maternal morbidity and mortality. Acute pyelonephritis is a common antenatal infection to cause sepsis. The quick sequential organ failure, whatever, SOFA score can be used to quickly identify early sepsis. This score is based on mental status, systolic blood pressure, and respiratory rate. A score of 2 or 3 points indicates high risk of sepsis. Management is similar, both gravid and non-gravid women. It includes treating the underlying infection and providing free resuscitation and hemodynamic support. So it would be sepsis if she had mental status, systolic blood pressure low, and respiratory issues.
Systolic blood pressure is low.
Yeah, but that's only one. She doesn't have any mental issues and she doesn't have Let me see the respiratory rate. They
Rate.
didn't do the respiratory rate. So she has to have two or three this out of these three to be
Okay.
sepsis. Okay. Next.
A 22-year-old woman, gravida 2, para 1, 38 weeks of gestation, comes to the physician for a routine prenatal visit. She feels well she feels well other than intermittent low back pain. Her pregnancy has been uncomplicated. Pulse 100, blood pressure 130 by 90. Physical examination shows no abnormality. The estimated fetal weight is 3.6 kg. The fetal heart rate is 120. The cervix is 4 cm dilated, 100%. 4 cm dilated, 100% effaced. Vertex is at -1 station. Which of the following is the most likely cause? Have you given your answer because your screen is stuck?
Jesus Christ. I don't know what's happening.
It never happened. I don't know why it is happening because I can see you like what you are doing. That's why I kept quiet.
Oh, that sucks. Okay, what is the
Do
issue? She
do
feels
you need
well.
to restart the computer?
Maybe, yeah. Let's after this question, let me restart it.
Okay.
Mature gestational hypertension. Maybe fetal heart rate. Fetal heart rate is fine. Cervical insufficiency. Is it normal labor? Maybe cervical insufficiency. I don't know. Okay, ready?
Okay.
Okay, it's normal labor. The first stage of normal labor involves the onset of regular uterine contractions. Okay, and cervical changes. Cervical changes in labor include effacement, the gradual thinning and shortening of the cervix. Oh, that's what effacement means. Cervical dilation and cervical dilation. Okay. As in this patient, cervical changes may precede regular contractions, engagement of the fetal head signified by negative tension, and the rupture of membranes. Okay. During the second stage of labor, the cervix is fully dilated and the fetus is delivered through the vaginal canal. Okay. The placenta is delivered during the third stage of labor. The fourth stage of normal labor includes recovery during the immediate postpartum period. Okay, so cervical changes, contractions, and rupture of membranes. Okay. It's not Braxton Hicks contraction are sporadic, irregular, and usually mild contractions are developed during the second or third trimester without cervical changes. These contractions do not signify the onset of labor. Cervical insufficiency exists uh, when the cervix is unable to retain a pregnancy in the absence of signs and symptoms of labor during the second and third trimester. Hmm? Okay. While this patient presents with evidence of early term delivery, cervical insufficiency will present earlier. Cervical insufficiency can be treated with cervical setback. Wait, cervical insufficiency exists when the cervix is unable to retain a pregnancy in the absence of signs and symptoms of labor during second and third. Okay. Gestational hypertension defined as blood pressure greater than 140/90. What she has. Okay. Develops after 20 weeks and is distinguished from preeclampsia by absence of proteinuria and organ damage. It does not contribute to cervical effacement or dilation. Okay. Okay, let's take a break. Let me close and open. Oh, turn off and turn back on my computer.
Sorry.
Oh, let's take a break. I'm going to turn off my computer and turn it back on. See
Okay.
if it does something. Okay, ready.
Question 9. Uh, A 15-year-old girl is brought to the physician, 3-day history of fever, abdominal pain, and nausea. She has had a thick white vaginal discharge, menarche at the age of 13 years. Her menses occur at regular 28 to 40 days of intervals. She became sexually active 1 month ago, uses condom inconsistently. Her temperature is 103, pulse 108 per minute, respiration 20 per minute, blood pressure 102/80. Examination show lower abdominal tenderness. Pelvic examination shows pain in the cervical. Pelvic examination shows pain in the cervical motion and adnexal tenderness. Pain in the cervical motion and adnexal tenderness with a 3 centimeter mass. A gram stain of vaginal discharge show gram-negative diplococci. Which of the following is most likely explanation in this patient's susceptibility to this condition?
Maybe.
Yes,
So it's increased cervical cell vulnerability to infections. Neisseria gonorrhea gram-negative Staphylococcus that can present with cervicitis, PID, Fitzhugh-Curtis, whatever syndrome, disseminated gonorrhea, septic arthritis, urethritis. When causing vaginitis, gonorrhea typically presents with mucopurulal and discharge and pruritus. Although patients may be asymptomatic, cervicitis presents with red friable cervix with cervical motion tenderness. When it spreads to fallopian tube and ovaries, it may cause tubo-ovarian abscess, presenting as adnexal tenderness and adnexal mass. This patient exhibits an increased cervical cell vulnerability to infection because of cervical ectopy in adolescent females. The ectocervix typically consists of squamous epithelial cells, and cervical ectopy refers to presence of columnar epithelium on the ectocervix surface, which is a potentially normal finding on adolescent females. Ectocervicals. Okay. The area of cervical ectopy is fragile and decreases the effectiveness of the mucosal barrier, placing the patient at increased risk for STIs such as gonorrhea. It's not an immature immune system will be unlikely in this patient at 15 years old. The immune system is immature at birth because of decreased concentration in immunoglobulins such as IgG. But as the infant matures and creates its own immunoglobulins, the immune system becomes more robust. And it's not menarche occurs on average between 12 to 13 years of age. So menarche before 18 of years of age is not uncommon and will not increase susceptibility to STI. Next.
a, a previously healthy 5-year-old girl is brought to the physician because of 2-day history of 5-year-old girl is brought to the physician because of 2-day history of foul smelling, white discharge, vaginal spotting on her underpants. She has she has not had pain with urination. Physical examination shows no abnormalities. Pelvic examination shows mild vulvar erythema and purulent discharge at the vaginal opening. Which of the following is the most likely cause?
Vaginal spotting.
Vaginal
Vulva is red. Between D and E,
Yes,
sexual abuse and vaginalism. The vulva is red.
vulva
Foreign
is
body.
red and there is a purulent discharge.
No, the purulent discharge can be the foreign body. Yeah, it can
Mm,
cause purulent discharge. But vulva is red. It wouldn't be foreign body. Would it? Okay,
I think
let's
that
just.
okay, you are what you have picked.
Uh, D, can you see my screen?
Yes,
Okay, ready?
yes.
Oh, it's foreign body. Vagina, vagina foreign bodies can present in prepubertal children with genital discomfort, vulvar, I guess, yeah, vulvar redness, vaginal discharge, or vaginal bleeding. Okay. The most common foreign body is toilet paper, but other subjects such as small toys parts and coins may be inserted because the child's curiosity and exploratory genital play. Diagnosis with visualization of the vaginal valve, saline irrigation, or exam under anesthesia may be required. Treatment requires removal of the foreign body. It's not sexual abuse is a rare in rare cases can be associated with vaginal foreign body, but is more often associated with with genital trauma, such as cervical or vaginal lacerations. Okay, we should see a laceration. And bleeding. Young children more often may insert objects out of curiosity and exploratory genital play. Okay, so lacerations will be the key there. Okay,
Okay.
next.
A moderately obese 27-year-old woman, Gravida 1 Para 1, comes to the physician because of pain and tenderness in her left thigh. Pain and tenderness in her left thigh for 2 years. For 2 days. She delivered a healthy newborn at term 6 days ago. Examination showed tenderness and swelling over the left thigh and calf. The there is pain. There is pain in the left calf with dorsiflexion. There is pain in the left calf with dorsiflexion of the left foot. Which of the following is the most appropriate next step to confirm the diagnosis?
Ready?
Yes,
Doppler's venous ultrasound. Uh, this patient presents with clinical symptoms concerning for DVT. Pregnancy represents a hypercoagulable state during which we already know the coagulation factors are overexpressed and the anticoagulant is underexpressed. Similarly, hormonal changes and compression of the yeah, we already know that one. Uh, Gravid patients are therefore at increased risk for DVT and subsequent PE throughout pregnancy and in the postpartum period. DVT presents with unilateral lower extremity pain, redness, edema, along with tenderness on palpation and pain exacerbated by passive stretch of the foot, so the dorsiflexion. Occasionally, a palpable thrombosed superficial vein is present. Further evaluation should be performed to confirm the diagnosis. Doppler venous ultrasound is the most appropriate next step. A patient pretest probability for DVT and PE can be estimated using the West criteria. It's not Doppler flow study. Uses ultrasonography to visualize the movement of blood flow to the vasculature. The frequency shift of ultrasonography waves return to the probe from moving tissues uses the Doppler effect to generate an image of blood flow. In contrast, Doppler venous ultrasound combines Doppler flow with B-mode ultrasonography imaging to provide more detailed imaging of the venous structures. Don't understand this. Impedance plethysmography measures the delay in venous emptying of the lower extremity after the release of pneumatic cuff. Okay, delay emptying after release of cuff can be indicative of venous thrombosis. This method is less sensitive than Doppler ultrasound and is not the preferred method for diagnosis. Okay. Fibrinogen-less scanning utilizes IV injection of radiolabeled fibrinogen which once incorporated into the venous thrombus can be visualized using nuclear scintigraphy scanning. This test is not preferred over ultrasound as it exposes the patient to radiation. Okay, next.
Okay.
Mhm.
A 20 and a 21-year-old primary gravid woman at 8 weeks of gestation comes to the physician for her first prenatal visit. She has sickle cell disease and is concerned about the risk of transmitting the disease to the fetus. Her pregnancy has been otherwise uncomplicated. Examination of shows a uterus consistent in size of 8 weeks of gestation. Yeah, her husband has hemoglobin electrophoresis. Hemoglobin A is 42%, A2 is 3%, F is 2%, and S is 53%. The patient should be counseled for the probability of her fetus of sickle cell disease to which of the following? Sickle cell is autosomal recessive, isn't it?
Autosomal recessive, yes, I think. Ready?
The patient should be counseled the probability of the fetus will have sickles. Okay.
Okay, so it's 50. Dang it. The probability that this patient fetus will have sickle cell disease is 50. Sickle cell disease is autosomal recessive condition and is inherited in the normal Mendelian fashion. Hemoglobin S, the abnormal hemoglobin that defines sickle cell disease, results from a point mutation in the beta globin chain, whereby valine is substituted by glutamate at position 6. The resulting combination of two alpha globin proteins and two sickle cell globin proteins is called hemoglobin S and results in a hemoglobin molecule that is poorly soluble when deoxygenated. Um, Under situations of decreased oxygen tension, hemoglobin S polymerizes into long hemoglobin structures that distort the erythrocyte into the classic S-shaped, sickle-shaped. The erythrocytes are poorly distendable and become lodged in the capillaries, leading to vascular occlusion and painful sickle cell crisis. This patient has two sickle cell beta hemoglobin mutation and thus has sickle cell disease. Her husband hemoglobin electrophoresis suggests that he has sickle cell trait. Oh, okay. Which means that he possesses one abnormal sickle cell beta globin gene and one normal beta globin gene. Patients with sickle cell trait have an elevated concentration of hemoglobin A, low but not absent concentration of hemoglobin A2, low concentration of hemoglobin F, and low but not absent concentration of hemoglobin A. The patient will pass one sickle cell beta globin to the fetus, and father has 50% chance of passing the sickle cell beta globin mutation to the fetus. Thus, there is a 50 chance that the child will inherit two sickle cell beta. Okay. 100% describes the risk of the child having sickle cell disease if both parents have sickle cell disease. If there was the case, the father hemoglobin electrophoresis will be expected to show absent hemoglobin A, A2, higher hemoglobin A, and very high hemoglobin S. Okay, let me see. So she has
So can you explain?
A, A. Okay, 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 makes sense. Um, I don't know
if
how can
both
I.
if both
Okay,
parents have okay,
it's like the you have to do the that thing, that square thingy.
got
I don't
it.
know how to do it. Okay. So the mom will have the mom is she has the disease, so she has the little a, whatever. And the dad only has the trait, so she has the normal and the disease. So the combinations will be this, and this is normal. I mean, the trait, not the disease. And these two are the disease. So the child will have 50% chances of being just sickle cell trait and 50% chance of having sickle cell disease. Does it make sense?
If like mom has disease and mother has sickle cell disease and father is normal
Yeah. Yeah. No, mom has sickle cell disease. Father has sickle cell trait.
trait.
Trait. Yeah, he doesn't have the disease. That's the part that we didn't get from this. From this is just the trait, it's not the disease. From the what they gave us. So that's the
Okay.
mom and that's the dad. Okay, whatever. I don't know.
So if both
Does it,
have sickle cell disease, then it is 100%.
then it's 100% because this one would be little a too.
Okay.
Okay.
Okay. Can you give me a